Aloha, welcome back to General Pharmacology. We'll move with the PowerPoint slides and get started, so maybe we'll get done on time today. Cancer and chemotherapy used to be the second lecture in section 5, and then I moved it back to 5.1. In the future, we're going to move this back to 5.2 for those of you in the future. The section 5 material gets mixed and remixed in different ways just depending on what's going on with the course. And so today we'll go ahead and start with cancer and chemotherapy because that's more fun to give. and hopefully my voice hangs in there for the entire day. So that being said, let's talk about the first cancer and chemotherapy lecture, which is about cancer. Although there are many types of cancer, they all start because of out-of-control growth of abnormal cells. Normal body cells will grow, divide, and important here, they die. In medicine, we call that apoptosis. And they grow, divide, and then die, get recycled in this orderly fashion. However, cancer cells undergo some kind of change that causes them to grow rapidly, but not only do they grow rapidly, but they also don't undergo apoptosis as they're supposed to. So because cancer cells continue to grow and divide, they are different from normal cells, and instead of dying, undergoing apoptosis, they outlive normal cells and continue to form new abnormal cells. So this rapid, uncontrolled growth compresses on surrounding anatomy, and it also releases abnormal hormones. We talked about this with SIADH. Lung tumors are notorious for secreting antidiuretic hormone. Lung injury is notorious for secreting antidiuretic hormone. But there are other hormones associated with cancers as well. This rapid growth will exceed the blood vessel's ability to supply inside of the tumor, and so inside of the tumor can result in cellular death, necrosis, and that can release all sorts of toxins into the body. Cachexia is severe malnutrition. All of these things are part of the cancer picture. All right, so cancer cells develop because of damage to DNA and its regulatory mechanisms. That's why we talked about DNA in the second lecture. So when DNA becomes damaged, the body is usually able to repair it. In cancer cells, however, the damaged DNA is not able to be repaired. People can inherit damaged DNA, and that results in about 10% of all cancers. More often, though, a person's DNA becomes damaged by exposure to something in the environment, or even random cellular events. As our cells divide, there are random cellular events that cause changes in the DNA sequence, and sometimes that can result in cancer. Things we know cause cancer in the environment: ultraviolet rays, drugs, asbestos, alcohol, smoking. Please stop smoking. Please drink less. Please avoid asbestos and illicit drugs, and ultraviolet rays. Viruses can cause cancer. HTLV, human T-cell leukemia virus 1, is the agent that causes a certain type of T-cell leukemia. Onco, as in cancer, genic to form from the beginning. There are oncogenic viruses out there, other oncogenic viruses, and they have different effects over the regulatory mechanisms of the DNA. Well, your body is designed to recognize these cancer cells and attack them using cytotoxic mechanisms in our immune system. And so this is a normal thing going on in your body. These cancer cells can develop, and your immune system can recognize them and launch an attack against them. However, sometimes those cells can rapidly divide to the point where it exceeds the body's ability to fight with those cancers, and then the tumor begins to grow out of control. Most cancers originate from almost any cell in the body and usually form a solid tumor. However, there are leukemias, myelomas. They're sometimes referred to as the blood tumors, the liquid cancers. These cancer cells involve the blood and the blood-forming organisms and circulate through other tissues where they grow. Somebody was asking me yesterday about hematogenious cancers. Hemato as in blood, genus to form from the beginning. Hematogenious cancers develop or spread through the blood system. This term is thrown around, the difference between sarcoma and carcinoma. Where's sarcoma? There it is. Sarcoma and carcinomas. I want you to know the difference between these two. When you see the abbreviation CA, that CA doesn't stand for cancer. That CA stands for this, carcinoma. And carcinomas are tumors that arise from cells that cover the external and internal body surfaces. All right, so the external body surfaces, that's easy to remember. That's your skin. But if you think about it, as you breathe in air, that air goes into your lungs, and you think of that as inside of the body. However, those cells that line the lung, they divide the outside world from the inside world. And so even though that air is inside of your lungs, it's still part of the outside world. Same thing with your gastrointestinal tract. Food comes in, food goes out. And that lining of the gastrointestinal tract separates the outside world from the inside world. And that applies to the reproductive organs as well. And so that's what they mean by internal body surfaces, those internal body surfaces that are still separating the outside world from the inside world, like the bladder. The bladder and the ureters lead to the outside world, and so those are cells that divide the outside world from the inside world. So tumors that arise from any of those cells are referred to as carcinomas, and they're the most common type of cancer. And so lung cancers, breast cancer, colon cancer, prostate cancer, these are all very common carcinomas. Adeno means it comes from a gland, and so an adenocarcinoma means that the cancer originated from some kind of glandular tissue. And so that's the meaning of adenocarcinoma. Quite simply, a carcinoma that originated from a gland. Some common adenocarcinomas: esophagus, stomach, bowel, colon, pancreas, breast, lung. These can all develop adenocarcinoma. I know we'll make this point eventually, but I'll make this point right now. I remember when the President of the United States, he was Richard Nixon at the time, said that during his administration he would find the cure for cancer, as if cancer was one disease with one cure. And that's not the case at all. Each of these different types of cancers that we're going to talk about, each arise from a different organ, a different cell in a different organ. And so each of these cancers are actually different disease processes. They're going to get treated in different ways. And so the cancers are not all the same disease process. They're each different. And that's why you'll notice that the treatment for esophageal cancer is not the same as the treatment for breast cancer or the treatment for lung cancer, because it's not a single disease. Cancer is not a single disease. It's many diseases lumped into one single term. All right, so squamous means flat. Anything that rises from those flat squamous cells that line the skin, the mouth, the tongue, the bladder, the reproductive organs. Those are all called squamous cell carcinomas. I want you to know the difference between carcinoma, which is abbreviated CA, and sarcoma, which is abbreviated SA. Sarcomas are not carcinomas. So carcinomas arise from the body linings. Sarcomas arise from the internal tissues of the body: bone, cartilage, fat, connective tissue, muscle. Those don't separate the outside from the inside world. They're part of the internal structures. And so when they arise from the internal structures, those are called sarcomas. I want you to be aware of that, because that's sometimes confusing for people. Lymphomas are cancers that arise in the lymph nodes and tissues of the body's immune system. Leukemias, leuko as in leukocyte, emia as in excessive growth in the blood, a condition of the blood. Leukemias are cancers of immature blood cells that grow in the bone marrow and tend to accumulate in large numbers in the bloodstream. There are leukemias that will involve more than just white cells. However, that's how they got their name. This is something very important to know when we're talking about cancer in a professional setting. And so the place where a cancer starts is called the primary site. And so if the cancer begins in the lungs, then the primary site is the lungs. Now that cancer might spread to other places, but it will still be called lung cancer. If it spreads to the brain, if it spreads to the liver, it's still called lung cancer. So from the primary site, it spreads to other parts of the body, and that spreading is called metastases or metastasize. When the cancer metastasizes, that means it's spreading to other parts of the body. And those cancers that spread to the other parts of the body, it'll be called a metastasis, which is singular, or metastases, which is plural. But again, it begins in the primary site. And so I've heard people talk about cancers that the primary site is the ovary, and yet it would spread to another part of the body like the brain, and they would say, oh, well, it was brain cancer. But we always name the cancer for where its primary site is. Even if it spreads to other places, we'll still call it the name of its primary site because that's the disease that we're dealing with. So regardless of where the cancer spreads, it is always named for the place it began. So breast cancer that spreads to the liver is called breast cancer, not liver cancer. And this is very confusing for our patients and other healthcare professionals. So this is something that I want you guys to keep in mind when you're dealing with cancer and chemotherapy. Cancer is always named after its primary site. All right, well, I told you my Richard Nixon curing cancer story. All the different cancers are quite simply different diseases. They all require different treatments. There will be similarities, and we'll go over the similarities, but the treatment for lung cancer and breast cancer are very different because they're different diseases. They start with different cells. They grow at different rates. They're going to respond to different treatments. And so that's why people with cancer need treatment that is specific for their particular kind of cancer. And so when you're looking at the clinical discussion questions and you're asked to describe a specific cancer, I don't want you to just say lung cancer. I want you to remember that there's different types of lung cancers as well. And so you need to be specific about that when we're talking about the different types of cancers, because the treatment for small cell lung cancer is not going to be the same treatment for adenocarcinoma of the lung. All right, malignant means cancerous, benign means non-cancerous. All right, we've talked a couple times about malignant having nothing to do with cancer, like malignant hypertension has nothing to do with cancer. However, in the cancer business, malignant always means cancerous. Benign means not cancerous. So not all tumors that we find are malignant or cancerous. Some are benign or non-cancerous, and they don't spread to other parts of the body. And with very rare exception, they're not life-threatening. The rare exceptions are inside of the cranium, the brain has a fixed space, and so even benign tumors, when they become the size of a golf ball, about 3 centimeters, they can be life-threatening. And so keep in mind this benign word means not cancerous, doesn't spread to other parts of the body. However, if it grows inside of the brain and inside of the skull, then it can be life-threatening. Pretty much everywhere else, benign is not going to be life-threatening as long as it can spread, as long as it can grow without encroaching on very important organs. But what we want you to know, malignant means cancerous, benign means not cancerous. Try to remember that. All right, well, sometimes to figure out what the cancer is, we'll need to take a biopsy, and the biopsy is just quite simply a surgical sample of the suspicious tissue. We can do this with a large hollow needle. In some cancers, we can do that. Many times we have to do a surgical incision, a surgical removal of the cancer. There are plenty of cancers that we can determine the type of cancer quite simply through a needle biopsy. However, there are some cancers that we cannot, like certain thyroid cancers, cannot be differentiated with a hollow needle, a needle biopsy. And those are decisions that are made by the surgeon doing the case. This is important. All right, so the tumor is excised surgically, and it'll be sent to the pathologist for examination and diagnosis. Sometimes they'll do a frozen biopsy where they'll come back with a determination immediately. There's all sorts of special stains and dyes. But what I want you to know is the tumor is excised surgically, and it's sent to the pathologist for all the things that they do. They can tell us about the margins. And this is important in determining the treatment of cancer. So the pathologist, one of the first things they'll tell us if the biopsy is surrounded by normal tissue, or if the biopsy cut through the tumor. And that means part of the tumor has been left in the patient. That means the tumor's been cut through and maybe leading to hematogenous spread of that cancer. And so many times the treatment of cancer will have to do whether the margins are positive or negative. And so these are negative biopsy margins right here. And so here's my cartoon of a biopsy that we've taken, and the tumor is completely inside of normal surrounding fatty tissue. There is no tumor that's been cut through. And so this is normal, these are negative margins. That means the margin of the tumor has not been cut through. It's completely surrounded by normal tissue. However, it's not always possible to have negative margins. It's not always possible to biopsy a tumor without cutting through it. And so we want to take out the entire tumor at surgery. However, this biopsy, the tumor's been cut through. And so we see surrounding tissue here, but right at the margin of where we cut, we see the tumor is on the margin. And so this is a positive margin biopsy. And that tells us that tumor has been left behind. And this is not always unusual. It's not always possible to remove the entire tumor at biopsy. But what I want you to know is many times the choices that we make for cancer treatment have to do with whether our biopsy margins are positive or negative. If we have negative margins, meaning the tumor is completely within the biopsy, then maybe we will have to be less aggressive with the tumor instead, and be less aggressive with a negative margin. And if we have a positive margin tumor, maybe we'll be a little bit more aggressive, or a lot more aggressive, about treating the cancer because we've left some behind, and cutting through it is also the risk of it spreading more. And it's not always possible to have negative margins at every biopsy. So in addition to the margins, the pathologist can tell us all sorts of things that we need to know. The gross description, that means that can be seen with the unaided eye. And then the microscopic description. So the gross description is what we can see. Microscopic description we have to see under a microscope. So one of the things that we'll want to know is the size. This is very important when we get to staging, because staging is going to help us not only determine prognosis, but staging is going to tell us the appropriate treatment for that cancer. So what can we see on the microscopic description? On the margin, certain cellular characteristics, its histologic grade. There's all sorts of interesting special staining techniques. And we could spend an entire semester talking about this slide right here, which would be a lot of fun. However, we have to move on. Histologic grade tells us how abnormal the cancer cells are. The low-grade cells are well differentiated. High-grade cells are poorly differentiated. And so this will be an important determinant in many cancers to see what our histologic grade is. If the cells are very well differentiated, we're going to be less aggressive than poorly differentiated cells. So we talked about differentiation when we were talking about going from a stem cell to its final form. And so when we talked about hematopoiesis, we talked about a stem cell becoming a certain type of progenitor cell, and it develops into its final form. And so the more it looks like its final form, the more it is differentiated. And so when we see cells that look more like they're immature, that's going to be poorly differentiated. We see cells that look like they're more mature, they're going to be well differentiated. And how well differentiated they are determines their histologic grade. And again, there's all sorts of interesting stains to reveal all sorts of characteristics of the cancer. Hopefully, as we move forward, we can talk about a lot of that, or some of it. All right. To understand staging, you really have to look up each individual cancer to know how it is staged. We'll talk about the common characteristics of staging today, but to know how a cancer is staged, you really have to look that up, and we show you that in the clinical discussion section. You really have to look it up and find out each individual cancer and how it's staged. When I was practicing medicine, when I was a resident and first learning all this, it was very difficult for me to realize that breast cancer and lung cancer are staged completely differently. But when you realize they're completely different diseases, then it makes sense that they're going to have different staging systems. All right, so this is in big yellow print. Staging reflects the amount and location of cancer in the body to make sure a person gets the proper treatment for their specific cancer. So the treatment for stage 1 breast cancer may be surgery and radiation, while a more advanced stage of breast cancer, 2 or 3, might require chemotherapy as well. Staging also helps predict the course a cancer is likely to take. Staging implies prognosis. And so I hear stories all the time of somebody being said, oh, well, the doctor said I only have 6 months to live, or I have this type of cancer, I'm only going to live 2 or 3 years. And that's not really how we describe staging as prognosis. Staging tells us what is the probability of surviving for 5 years. 5-year survival is a typical prognostic goal. And so with certain types of cancers, maybe there's a 50% chance of surviving 5 years. Certain advanced cancers, maybe there's a 50% chance of surviving 1 year. And so when we truly describe prognosis, we describe it as the probability of surviving 1 year, surviving 5 years, and anything in between. And so keep that in mind when people are saying, oh, well, you only have 6 months to live. That means that the 1 year survival is about 50%. Other people will live much longer than that. However, it's about probability, and so keep this in mind when we're talking about prognosis. We're talking about the probability of a 5-year survival. We're talking about the probability of a 1-year survival. Try to keep that in mind. All right, so we're going to learn this TMN staging, which applies to everything except leukemia and the hematogenous cancers. And so we'll talk about staging leukemia, hopefully. Cancers around the brain are not staged this way either. I was going to throw that in. However, for the near entirety of cancers, I want you to know the TNM staging of cancer. And so this will be whether it's carcinoma or sarcoma, as long as it's not certain cancers in the brain or leukemias, we're going to stage them using the TNM staging system. Few cancers are really aggressive, like small cell lung cancer. It's really aggressive. We don't really stage it TNM because it moves so quickly. But for the near entirety of cancers, we are going to use this TNM staging system. T stands for the tumor size and other characteristics of its growth and surrounding areas. N has to do with lymph nodes that are involved. M has to do with whether the cancer has metastasized to different areas of the body. And so once we've scored the T and the N and the M, then we can take that and translate that into staging. And that is information that you will need to specifically look up if you want to know about these things. There aren't too many people out there who have all of this completely memorized. All right, so T usually describes the primary tumor and its size, the original primary and its size. So it'll be numbered T1 to T4 depending on the tumor size or the level of invasion into nearby structures. The higher the T number, the larger the tumor, or the further it is grown into nearby structures. T0 means there's no evidence of the primary. TX means we can't measure it or figure that out. TIS is important. TIS means cancer in situ. And that means that the cancer is specifically within a space that is not grown into surrounding structures. And in situ means it's well demarcated. It means it's within its specific space and is not grown into surrounding tissue. And so sometimes it's not so much the size, it's whether the tumor has extended into the structures around it. And so we'll see those things. However, what I want you to know is these things are staged T1, T2, T3, T4, depending on the size. Of course, there are exceptions. The N category describes whether or not the cancer has reached nearby lymph nodes. Something that we do in breast cancer is we look for the sentinel lymph node. We try to find the first lymph node that the cancer would spread. And so if we find that lymph node, if we can see that the cancer has expanded into the nearby lymph node, then we can categorize N. So N0 means there's no lymphatic spread. N1 to N3 describe the size, location, the number of lymph nodes involved. The different cancers are going to have different N1 to N3 categories. Right? NX means we can't figure it out or it can't be measured. Right? So X generally means we're not sure. The M category tells us whether there are distant metastases or spread of cancer to other parts of the body. M0 means there were no distant metastases found. M1 means that they have been documented. M1 means that distant metastases were found. MX means that it's not something we can measure or evaluate. Something to keep in mind is even though we don't see distant metastases, we can see from cellular characteristics something called micrometastases, where the cancer is spreading to other parts of the body, but we haven't determined that yet. But what I want you to know, M0, no metastases, M1, distant metastases. All right. So again, T, tumor size, N is nodes, the number of lymph nodes involved or whether lymph nodes are involved, and M means metastases, whether metastases are involved. And again, each primary, because it is its own disease, has its own version of this classification system. So the numbers and letters aren't always going to mean the same thing for each kind of cancer. And this bothered me going to school because I like things to be very organized, like the PowerPoint slides. I want this to be this and that to be that, and I don't want all this messy stuff in between. And so learning cancer staging systems was difficult for me because every one of them was different. And so I think we've made the point. Some cancers are going to have subcategories, like there might be T3A and T3B. If you watch my lectures, you notice that we've split them up a certain way, and then we split them up some more into A and B. We have to do the same thing with this. And then maybe some cancers don't have N3. Maybe it just has N0 and N1 for its staging system. And this is why right here, because staging helps us predict the course a cancer will take. Staging implies prognosis. Their 5-year survival, a 1-year survival. What is the probability that this person, if they undergo full treatment, will survive 1 year? What is the probability if this person does not undergo treatment that they will survive 1 year? What is the probability of them surviving 5 years if they do undergo treatment? What is the probability of them surviving 5 years if they don't undergo treatment? These are the things that staging tells us. So once the biopsy's been done and the various scans, the various tests and investigations, we can have once we've scored the T, N, and M, then we can put those together and have an overall stage. And the overall stages are 1, 2, 3, and 4. 4 is always late stage cancer and usually always has distant metastases. Well, the earliest stage of cancer is 1. And so 1 is an early stage of cancer, 4 is the advanced stage of cancer. And then sometimes they'll divide it up into 3A and 3B. All right, so stage 1 breast cancer, T1, N0, M0 breast cancer. What does that mean? All right, well, a T1 means less than 2 centimeters across on gross description or gross examination by the pathologist. There were no lymph nodes involved. We went looking for lymph nodes. We looked for the sentinel lymph node. We did not find one, so we have N0. If we don't know, we put NX. Here, we know there's no lymph node involvement, and there's no metastatic spread of the cancer. There are no distant metastases. And so this is how we've staged this as stage 1 breast cancer. And so maybe that treatment is going to be different than stage 2 cancer. So here we have T2 N1 M0 breast cancer. That means the cancer is more than 2 centimeters. That's what T2 means. But less than 5 centimeters. So T2 is in between 2 and 5 centimeters. And it has only reached one of the proximal lymph nodes, but is not metastasized. And so this would be 2B breast cancer. All right. This is something that you want to know when you are reporting cancers. The important point that some people have trouble understanding is the stage of cancer does not change over time, even if the cancer progresses. This is important for statistical reasons, and we'll tell the story why here in a second. But when you deal with reporting cancers, when you talk about treatment of cancer and reporting those cancers, the stage of the cancer does not change, even if the cancer progresses over time. So if somebody starts out with stage 2 breast cancer, we're going to call it stage 2 breast cancer even if it advances over time. And some people say, oh, let's advance to stage 4 cancer. And from a clinical point of view, we don't restage them in the description of the disease. And that's important for the people who take care of cancer statistics, that we're not changing the stage when we're reporting the cancer disease to them. However, I did some work for the federal government evaluating veterans for their different needs. And one of the things that they asked me to do was restage somebody's cancer, because the cancer had advanced and their retirement and pension remuneration had to do with the stage of the cancer. And so in their retirement system algorithm, stages do change. And so they sent this person in, they're like, well, this cancer is advanced. what is their new stage? And this is the point that the physician made. Staging doesn't change. And so that was a problem. So they sent them to me and they said, look, if his cancer has progressed, then he is entitled to more compensation, but that's if you will restage his cancer. And so I did. And if you go back to nominal nomenclature, we talked about, well, is the sky blue or not blue? Is a 2x4 really 2 inches by 4 inches? And the answer is like, well, no, it's kind of, but not really. And I've noticed that this initial stage, the stage based on initial diagnosis, is important for people keeping statistics. However, people who deal with retirement and compensation, they will want to see this change. And so whether the stage is based on initial diagnosis or changes over time depends on who you're talking to. And so this is what I want you to remember, that even though we don't change the staging when we talk about it professionally for statistical reasons, there are people out there who will ask you to restage the cancer for purposes of compensation, pension, that sort of thing. So try not to get stuck and unwilling to be flexible, because not everybody understands this point right here. A cancer that comes back or spreads is still referred to by the stage it was given when it was first diagnosed. And I think we've made that point very clear. All right, so let's talk about some common features of cancer chemotherapy agents. Something I want you to keep in mind is if you go through the different books, they'll list these drug classifications differently. Every time I look at something about the classifications of cancer chemotherapeutic agents, I see a little bit different list than the one I use. So keep that in mind, that the list I use is not the exact list everybody else uses. But when I put this together, these were the lists that were put together from the the cancer.gov. That's the website that I use to put a lot of this together. Because we're at the point where a lot of this stuff I have to get from websites as well. All right, so we're going to talk about alkylating agents, something called the antimetabolites, plant alkaloids, antibiotics, hormones, and biologic response modifiers. The bottom one has all sorts of terminology that goes with that, and we'll try to touch on that. All right, so cancer chemotherapeutic agents, many of them are described how they affect the cell cycle. And so this is where we'll start. As we get more advanced, we realize that it's not this simple. Many of the cancer chemotherapeutic agents we see today do not have this simplicity, but a lot of the traditional agents we use are involved. We do describe them where they fit in the cell cycle. So let's see if I have, all right, great. All right, so the M phase is mitosis. And so this circle, this is supposed to be a circle, and it's supposed to be a clock. And so if this is the amount of time that the cell undergoes between each mitosis, then mitosis, you can see, is a little bit of time on this clock. All right, so drugs that block mitosis will be called antimitotic, M phase, cell cycle specific. That means that the drug affects mitosis and affects the cell division during mitosis. And so look for drugs that are antimitotic. They're M phase, cell cycle specific. All right, well, after mitosis, the cell spends half of its time in that first growth phase. And so that'll be called G1. And we'll see some drugs that are G1 cell cycle specific. A lot of the drugs we see are S phase cell cycle specific. So the S phase is the synthesis phase. Now, throughout cancer and chemotherapy, and including antimicrobial agents, we'll see a common strategy is interfering with DNA and RNA replication will interfere with the cancer. And so we'll see a lot of drugs that are cell cycle specific for the S phase. So drugs that block DNA synthesis will be S phase cell cycle specific. Many of the drugs that block DNA synthesis are considered S phase cell cycle specific. And then after the DNA synthesis, there's a second growth phase, and that'll be called a G2, and we'll see some G2 phase cell cycle specific, and we'll see some that are like both S and G2 cell cycle specific. Right, well, many drugs are not cell cycle specific. They are cytotoxic anywhere during the cell cycle, and they'll be called cell cycle non-specific, CCNS. And so keep this in mind as you're looking at regimens for the treatment of a specific cancer. Maybe they'll alternate between a cell cycle non-specific drug and then a cell cycle specific drug. And they'll use that terminology as they talk about the proper treatment. All right, so we're starting with alkylating agents and other agents that damage DNA and RNA. Chemotherapy agents that damage RNA and DNA are toxic to rapidly growing cells. And so that's why they're used to treat cancer. However, because we are treating cancers, because we're using agents that affect rapidly growing cells, it's going to be toxic to the rapidly growing cells in our body as well. And so one of the places we see rapidly growing cells is in hematopoiesis, our bone marrow. The blood cells, as they develop, are being driven by these rapidly dividing stem cells, and because of that rapid division, the agents that, other agents, let me fix that now. So again, alkylating agents and agents that damage DNA and RNA, they're going to be mostly toxic to rapidly growing cells. That's what we want. However, they're going to be toxic to other rapidly growing cells in our body. And one of the places that we see rapidly growing cells in our body are the cells that involved in hematopoiesis, the development of the blood cells, and that occurs in the bone marrow. And so you'll hear these agents referred to as bone marrow suppression. They cause bone marrow suppression, and that just means they result in low blood cell production. Pancytopenia is all of the blood cells. Maybe you'll hear neutropenia, meaning it's caused toxicity to, or caused interfering with the production of neutrophils, resulting in too few neutrophils. So neutropenia, too few neutrophils. Neutrophils are a type of white blood cell that we talked about in immunology. Agranulocytosis, without granulocytes. That's what agranulocytosis means, without granulocytes, or very few granulocytes. Neutrophils, my spell checker must be on today. I just went through all these. Agranulocytosis means without granulocytes. Neutrophils are granulocytes, and they're the most common granulocyte, and so you'll hear neutropenia and agranulocytosis used interchangeably, quite simply because basophils and eosinophils are the other granulocytes, and we don't really talk about them too much. We usually talk about neutrophils. So you'll see agranulocytosis and neutropenia being referred interchangeably. Agranulocytosis meaning all the granulocytes. Neutropenia is a subsection within that. All right, anemia, too few red blood cells. Pancytopenia, too few of all the blood cells. Pan, all. Cytocellpenia, too few. So maybe we'll use Neupogen, granulocyte colony stimulating factor, to stimulate neutrophil growth in somebody who has bone marrow suppression. We can use Epigen, which is Procrit, to stimulate red blood cell production if they are suffering from bone marrow suppression due to cancer chemotherapeutic agents. All right, because the cancer chemotherapeutic agents that damage DNA and RNA are toxic to rapidly growing cells, they're going to be toxic to the gastrointestinal tract because the cells that line the gastrointestinal tract are constantly being scraped and eroded by the things that you eat. And so the gastrointestinal tract must rapidly reproduce those cells because of their rapid degradation due to food passing through the gastrointestinal tract. So that's why these agents cause nausea and vomiting, stomatitis, inflammation around the mouth. Now, it's important to research these things and look them up because I've heard countless stories about somebody who went in and met a patient and they're just like, oh, we're starting this cancer chemotherapy on you and it'll cause nausea and vomiting and hair loss and stomatitis and bone marrow suppression. And not all cancer chemotherapeutic agents are toxic in this way. It's the cancer chemotherapeutic agents that damage DNA and RNA in rapidly growing cells, like the alkylating agents that cause bone marrow suppression and damage to the gastrointestinal tract. All right, your hair follicles are another place we can find rapidly growing cells, and so this is the reason that these agents cause hair loss. And so when we use alkylating agents and other agents that are toxic to DNA and RNA production, affecting rapidly growing cells, in those cases then we can expect bone marrow suppression, nausea, vomiting, and stomatitis, as well as hair loss. And this is what we typically think of when we think of cancer chemotherapeutic agents. Bone marrow suppression, hair loss, nausea, and vomiting. But that's not all of them, so be very careful to separate the different agents and how and what their toxicities are. Because not all drugs used in cancer cause bone marrow suppression, nausea, vomiting, stomatitis, and hair loss. Always look these things up before you go in and tell the patient, oh, well, the person teaching me told me that cancer chemotherapeutic agents cause nausea, vomiting, and hair loss and bone marrow suppression. That's many of the drugs, and most of the time we will need to use drugs that do this, but not every drug causes these problems, so always use a drug reference. All right, we're talking about the alkylating agents. The first alkylating agents were derived from nitrogen mustards. Nitrogen mustards were used in World War I as a chemical warfare agent. This was mustard gas, and this caused blistering of the skin, vesicants. Vesicants cause blistering of the skin. So this is an important point to make right now. That's why it's important to have a special kind of clinician put an IV in a person who is receiving these agents, because if the alkylating agent extravasates, that means gets outside of the vein, it can cause all sorts of damage to the surrounding tissue. And so it's really important that the alkylating agents go in the vein and don't leak out, because they're called vesicants. They cause severe blistering. Something else I want you to know is that, and I wanted to have a slide about this, but you guys can look this up. There is a routine that we've been going through and still go through, where we have a culture of cancer cells that reproduce in a petri dish. We have a colony of cells reproducing in a petri dish, and we can add all sorts of substances. Every substance we can think of, we can add to that petri dish and see if they interfere with the reproduction of those cancer cells. And alkylating agents were the first thing we realized can stop the reproduction of cancer cells. All right, so again, the nitrogen mustards were were mustard gas used in World War I. And you can see he has these blisters on his body due to those nitrogen mustards, and so vesicants cause this, and so this is why it's really important when we're using an alkylating agent that actually go in the vein. And so that's why you'll see people with ports that will take a port and put IV access directly over their heart. So these, instead of these agents being applied to the arm and extravasating, causing damage to the tissues, we can mix it to the busiest place for blood collection, and that's just right above the heart, directly into the right atrium. And so that's why we'll put catheters in people who are getting cancer chemotherapeutic agents to avoid vesicants damaging the skin and the surrounding tissue. All right, so the alkylating agents form a reactive molecule species that alkylates nucleophilic groups on DNA bases, particularly the N7 position of guanine. I must have cut and pasted that from somewhere, but for you keeping score, that one's for you. Alkylating agents cross-link DNA during all phases of the cell cycle, resulting in disruption of cell function. So that's what I want you to know. These are not cell cycle specific. These are cell cycle non-specific. So alkylating agents disrupt the DNA function. They cause cell cycle arrest and cause the cell to undergo apoptosis. And again, that's the problem with cancer cells. Not only do they grow and reproduce rapidly, but they don't undergo apoptosis, which is cell death. And so this is one of the reasons alkylating agents are very effective at treating cancer. However, because they are damaging rapidly reproducing cells, alkylating agents will cause hair loss and nausea and vomiting and bone marrow suppression. And so we'll want to give them in bursts enough to damage the cancer, but not damage our patients so much. And so we'll give them a burst and then allow our patient to recover, maybe using a different agent during the recovery that's more specific to cell cycle. Again, the alkylating agents are cell cycle non-specific that damage DNA anywhere in the cellular cycle. Alkylating agents are cell cycle non-specific. And because they're vesicants causing blistering of the skin, these agents can be very damaging if they're not properly administered. And so, again, that's why we want somebody very special if we're giving this through an IV to start that IV. And most of the time we put them in a central catheter that delivers the chemotherapeutic agent right above the right atrium. So that is mixed with the largest volume of blood possible. And here's a list of some alkylating agents that are directly derived from the nitrogen mustards. Chlorambucil, cyclophosphamide, which is Cytoxan, and mecloethamine. These are nitrogen mustards. And one thing I wanted to point out is early in the class we talked about the Me Too drugs that, oh, here's ibuprofen, and we call it Advil. Oh, here's ibuprofen, we call it Nuprin. It's little yellow different. No, all the ibuprofens are exactly the same. That's not the case with the various cancer chemotherapeutic agents. When we go through the different cancer chemotherapeutic agents, these aren't really two of the same thing. They're each different and are going to have their different strengths and weaknesses with the different cancers. So I want you to get out of that mindset right now. When we talk about ACE inhibitors, as far as I'm concerned, all the ACE inhibitors are pretty much alike. When we talk about alkylating agents and other cancer chemotherapeutic agents within a class, I want you to think of them as being all a little bit different with specific indications for specific cancers. Other alkylating agents, busulfan, dacarbazine, procarbazine, carmustine, lomustine. Sometimes these are prodrugs of each other. I think we're going to talk about that. There are platinum analogs that are alkylating agents. You'll see that platin word at the end of their generic term. Those are the platinum analog alkylating agents, cisplatin, carboplatin, oxaliplatin. Then there are cancer chemotherapeutic agents that are called the anti-metabolites. And the antimetabolites interfere with DNA and RNA production as well. But the antimetabolites are S-phase cell cycle specific, meaning they're going to interfere with the S phase, the DNA synthesis phase of the cell cycle, which makes up, about a third of the cell cycle. Methotrexate is a folic acid antagonist, and it interferes with DNA and RNA synthesis by preventing nucleoside production. And so we'll use methotrexate for arthritis and other connective tissue disorders. However, we also use methotrexate as a cancer chemotherapeutic agent. And then we'll have the purine and pyrimidine antagonists. If you go back to lecture 2, we talked about the nitrogen bases being either purines or pyrimidines, and these antimetabolites interfere with the formation of purines and the formation of pyrimidines. And so mercaptopurine, thioguanine, these interfere with DNA and RNA synthesis by preventing nucleotide production. And again, these are S-phase cell cycle specific. All right, so the nitrogen bases come in purines and pyrimidines. That's why the antimetabolites will come as purine and pyrimidine. Some of the antimetabolites come as purine and pyrimidine antagonists. Again, they interfere with DNA and RNA synthesis by preventing nucleoside production. 5-FU is fluorouracil. Capecitabine is Xeloda, a 5-FU prodrug. So 5-FU is very toxic. We could not swallow 5-FU. It has to be given IV. And sometimes, since we're going to alternate that with a cell cycle non-specific agent, it's very important for the patient to be available for the IV therapy. However, recently we were able to come up with a prodrug for 5-FU, and that's the drug Xeloda. And so this means that if a person is going to be on 5-FU for a long time, maybe they don't have to go to the cancer chemotherapeutic, the cancer clinic to get IV 5-FU. They can take the drug by mouth and get a 5-FU regimen orally. And so this is something new that we're seeing. I saw somebody on vacation who the only reason that they were able to come to Hawaii is that they were able to use 5-FU orally rather than sticking around the cancer clinic to get their IV 5-FU. So Xeloda, a 5-FU prodrug, this was a big accomplishment for many people in the treatment of cancer. And so we like to ask that on board questions. They like to ask that on board questions. There's all sorts of these agents that come from plants. Not all the plant alkaloids have the same characteristics or the same specific cell cycle. The yew trees produce the taxanes. The taxanes interfere with microtubules and therefore are mitotic inhibitors. So the taxanes from the yew trees are M-phase cell cycle specific, meaning they interfere with mitosis. The yew trees produce taxanes, and here's some pretty pictures of yew trees that we put in the slides. Paclitaxel, which is a Taxol. Docetaxel is Taxotere, and these are some of the taxanes that are used as cancer chemotherapeutic agents. Then there are the vinca alkaloids from the periwinkles, the vinblastine, vincristine. These come from Vinca rosea, the periwinkle plant. They bind to tubulin and cause mitosis to stop. So the vinca alkaloids are M-phase cell cycle specific, as well as the taxanes. And it's the periwinkles that produce the vinca alkaloids. And here's a nice, pretty picture of vinca alkaloids. I got an email from someone who said, "Thank you so much for putting some color in your boring black and white slides." So we're going to try to do that a little more. That's why we see yew trees and periwinkles being M-phase, anti-mitotic M-phase cell cycle specific cancer chemotherapeutic agents. The camptothecans come from the Camptotheca acuminata tree, topotecan and ironotecan come from the Camptotheca acuminata tree. The camptothecans are topoisomerase inhibitors. When we talked about 1.2, right at the end of the lecture, we talked about different enzymes, different proteins that are involved in DNA and RNA regulation, zipping and unzipping and twisting. And so topo, as in topography, the surface of something, isomerase. Topoisomerase is an enzyme that's important for winding DNA around the places it winds around. And so if we can interfere with topoisomerase, this is going to interfere with DNA reproduction. And so the camptothecans are topoisomerase inhibitors. And they are S-phase cell cycle specific, meaning they interfere with DNA synthesis. All right, so keep that in mind as we go through the plant alkaloids. Not all of them are anti-mitotic. The camptothecans are S-phase cell cycle specific. And there is a picture of our Camptotheca acuminata tree. Epipodophylotoxin is from the mandrake root, specifically the Podophyllum pilatum, and it's a type of topoisomerase inhibitor as well. So the topoisomerase inhibitors, again, are S-phase cell cycle specific because they interfere with DNA synthesis, because topoisomerase is important in the regulation of DNA. Topoisomerase inhibitors are S-phase cell cycle specific. The mayapple plant produces epipodophylotoxin. All right, there are antibiotic agents. When we talk about antibiotics, we're going to see that a strategy that we use is the antimicrobial agents. One of the strategies is to interfere with DNA and RNA production. And so the very antibiotics that would be classified as antimicrobial agents, we can also use as cancer chemotherapeutic agents. Anthracycline is a type of antibiotic that comes from Streptomyces bacteria. The anthracyclines are used to treat all sorts of cancers. They not only block DNA synthesis, they damage DNA synthesis during all phases of the cell cycle. They're too toxic for bacterial infection. Danirubicin, doxorubicin, which is adriamycin, Alentz, epirubicin, idarubicin, and then an analog of the anthracyclines is mitoxantrone. And again, these are cell cycle non-specific, meaning they're going to be cytotoxic anywhere in the cell cycle. Bleomycin. Mycin, be on the lookout for that mycin word. That doesn't necessarily mean related to erythromycin. It means it's a polyketide that's plant-based, usually bacteria-based. All the little bacteria can make little substances to interfere with the other bacteria trying to encroach on it. So bleomycin is a type of antibiotic produced by the bacterium Streptomyces verticillus. Bleomycin not only interferes with DNA synthesis, but it damages DNA synthesis and is especially active during G2 phase. So bleomycins are considered a late S and G2 phase cell cycle specific. There's hormone modifiers, glucocorticoids. Glucocorticoids are based on cortisol, a naturally occurring hormone in our body, very similar to hydrocortisone. The gonadal hormone antagonists, gonads as in reproductive organs, and so we'll see estrogen antagonists and testosterone antagonists. Gonadotropic releasing hormone analogs, and aromatase inhibitors. Aromatase interferes. Aromatase is an enzyme involved in estrogen metabolism, so aromatase inhibitors interfere with that. So prednisone is a glucocorticoid commonly used in combination with other agents in the treatment of leukemias and lymphomas. Well, one of the uses of the prednisone is to increase white blood cell count to get the cells to demarginate, get the white cells to come out of the margins around the blood vessels and get back into the bloodstream. And so we will use glucocorticoids to raise blood cell levels. Tamoxifen Nolvadex is an estrogen receptor modulator. It's commonly used to treat and prevent breast cancer as well. Ulixin, flutamide, is an androgen antagonist commonly used to treat prostate carcinoma. Men have prostates, and so Ulixin is a testosterone antagonist used to treat prostate carcinoma. Lupron, which is leuprolide, and Gaserelin, which is Zoladex. These are gonadotropic releasing hormone analogs commonly used to treat prostate cancer as well. Aromatase is an enzyme important in estrogen formation, so aromatase inhibitors will be used to treat breast carcinomas. Arimidex and Femara are aromatase inhibitors. And then there's all sorts of cancers that are part of the, there's all sorts of cancer chemotherapeutic agents now that are part of the biologic response modifiers. Hopefully what I'm looking for is on the slides. We can use interferons. We talked about interferons when we talked about immunology. Interferons will interfere with the cellular mechanisms that viruses need to reproduce, and we can use the same interferons to interfere with cancer reproduction as well. And so interferon A is effective against certain leukemias and lymphomas. I want you to be on the lookout for this MAB word. That means monoclonal antibody. When you see an agent that ends in MAB, that's a monoclonal antibody, and we're seeing more and more and more of these, and this is getting more complex, and so I'm hoping the slide's coming up, but I think we'll have to add to that next time I sit and talk about this. Trastuzumab is Herceptin. It's a monoclonal antibody that binds specifically to a human epidermal growth factor receptor, and so cancers that express this receptor, trastuzumab, Herceptin, can effectively kill those cancer cells. Trastuzumab is traditionally used to treat breast cancers that are HER2 positive that have spread after treatment with other drugs. That's changed a little bit. I see Herceptin is being used sooner than this criteria right there. And again, the specific treatment for a specific cancer is something that you're going to have to look up every time, not rely on a PowerPoint slide that's several years old. Bevacizumab, Avastin, binds to vascular endothelial growth factor, preventing angiogenesis. So when we talked about the cancer cell growing, it requires all sorts of angiogenesis, all sorts of blood vessels to support that cancer. And so if we can interfere with the reproduction, if we can interfere with the formation of the blood vessels, we can interfere with the growth of the tumor as well. The NIBs, we'll see the ones that in a NIB, this one is a tyrosine kinase inhibitor. All right, is my slide on here? No. All right, when we talked about second messenger systems, we used specifically the case of cyclic AMP, where there's a receptor. If you go back to 1.2, there's a receptor, and then there's one intermediate G protein, and then there's adenyl cyclase. All right, and so we had a chain that was just one protein long. When you start studying these new agents in depth, you're going to notice that there's a signaling system, and it's very similar to our second messenger systems, where there's a receptor on the surface that then signals numerous proteins in that chain downstream to the cell nucleus to affect its inner workings. And so there are somewhere around 20 chains, intermediate proteins between the surface and the cell. And one of the places in that signaling system involves a tyrosine kinase. And so more and more we're seeing tyrosine kinase inhibitors that are being used as well. And if you study that signaling system from the surface to the control center in the nucleus, we're seeing more and more agents that affect the chain in that basically messaging, second messenger system. And so I had a slide on that, and I'll have to go back and find that. Tyrosine kinase inhibitors, we're seeing more and more. Adjuvant therapy is systemic therapy, IV therapy given to patients. Maybe they have no evidence of cancer after surgery. However, maybe we had surgery that removed all of the cancer, but because of histologic grade, some characteristics that we see, maybe we feel that the cancer is metastasizing even though we can't see it. It's metastasizing in the blood. And so when surgery has been removed surgery has removed all of the cancer, but we still use cancer chemotherapeutic agent, we'll call that adjuvant chemotherapy. Neoadjuvant chemotherapy will be given before surgery, and so sometimes we'll give the cancer chemotherapeutic agent, we'll give the chemotherapy before surgery so we can shrink the tumor or see if the tumor is responsive to the chemotherapeutic agent before surgery, and this allows us to be less aggressive during surgery. Drugs that are cell cycle specific will be used in alternating with cell cycle non-specific agents. We'll give the cell cycle specific drug and then use a non-cell cycle specific while they're recovering from the toxicity of the cell cycle specific drug. So we'll give intensive courses of cytotoxic agents, usually about 3 or 4 weeks apart, to allow the hematologic, the bone marrow, and the immune system to recover between courses. And then rescue therapy will be any agent that prevents or lessens the toxicity of cancer chemotherapeutic agents. And so if the cancer chemotherapeutic agent causes nausea, then using drugs like ondansetron to treat nausea, that would be called rescue therapy. Secondary malignancies can be caused by chemotherapy. Remember, chemotherapy damages DNA and RNA, and so many times we'll see children who have types of cancers, and we'll treat those cancers. Later on, they can develop other cancers that are caused by the cancer chemotherapeutic agents. And so many alkylating agents can cause cancer in the long term, especially when we use them in children. And so acute myelogenous leukemia as a late complication of chemotherapy is the most common treatment of Hodgkin's disease. And so what I want you to remember is that these agents can cause cancer down the long term. But don't take my word for it. Get your information here. This is an excellent website to get your cancer information, cancer.gov. Check out the website. One of your assignments in here is to pick a cancer that means something to you. Maybe you have a loved one with a cancer. Maybe you've heard of a certain type of cancer. Maybe there's a certain type of cancer you're interested in. Go to this website, read as much about that as you can. When you see a patient with cancer, the way you're going to get educated is not from some YouTube video teaching you or some television teaching you. Your patients are going to teach you. And so every time you have a patient with cancer, make sure that you understand its primary and its staging, and go look it up on cancer.gov, because if you take the opportunity to let your patients teach you, then you'll learn lots of information to be able to take care of people better in the future. The American Cancer Society has an excellent website for information as well, and that's cancer.org. All right, when we come back, we will talk about antimicrobial agents, and then hopefully maybe we can talk even more about cancer chemotherapeutic agents. And so until then, aloha.